The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. Sorry about a little bit of the technical difficulty there. I want to thank you for joining, and just a couple of housekeeping items before we get started. If you do have any questions, please enter them into your chat box. And to let everyone know, this will be recorded and archived on msdcenter.org. So you will find a recording of this webinar along with the PowerPoint presentation slides. And with that, I'll hand it over to Shrila Sharma and Melissa Danho to start the conversation on the natural experiment to promote obesity prevention behaviors among low-income pregnant women.
Thank you, Veronica, and good afternoon, everyone. So we are happy to present our HEAL program today, our Healthy Eating, Active Living, which was a natural experiment to promote obesity prevention behaviors among low-income pregnant women receiving care in OB clinics that primarily serve Medicare, Medicaid population. Just to start off, I am Shrila Sharma, and I'm a faculty member here in Michael and Susan Dell Center for Healthy Living, which is a research center at the UT School of Public Health. And the mission of our center is healthy children in a healthy world. Just to kind of lay a little bit of the groundwork behind why we designed and implemented HEAL, it's primarily from an obesity prevention perspective for children. And, you know, we have data for the last several decades that shows an increasing trend in obesity among children as well as adults, and right now the obesity rate is about 18.5%, with 13.9, almost 14% of 2 to 5 year olds being obese. And obesity increases with increasing age in the child, and there are also several racial and ethnic disparities, with the rates of obesity being highest among Hispanic and African American children. So clearly we have an ongoing epidemic of childhood obesity that seems to be persisting. In Texas, Texas, as everybody knows, can be its own country. It's very large, and 1 out of 11 children in the United States currently live in the state of Texas. One of the major issues we're dealing with as it relates to maternal and child health is that maternal mortality rate in Texas is not just highest in the nation, but also in the industrialized world, with 30 deaths per 100,000, primarily due to modifiable pregnancy-related ailments. And obesity is one of those ailments which can be prevented or cured. Also, maternal pre-pregnancy obesity rates in Texas have doubled from 13% over 20 years ago to now almost 25%. Concurrently, childhood obesity rates in Texas are among the highest in the country as well. So clearly those two are related. And this is sort of a figure that shows the relationship between obesity in the parent and how it translates into the child. This is a figure that's actually from Dr. Phil Nader's publication in Childhood Obesity back in 2012 that essentially called for a systems level thinking for an early life cycle approach to obesity prevention. And if you look at the figure starting left going to right, starting with pregnancy, you see that the area where you could have that intergenerational impact in mitigating risk for childhood obesity is the pregnancy period, because you could not just, by reducing obesity in the mother, you could also reduce the risk for obesity in the child. And if these issues are not addressed early on, then overweight adults are at a higher risk for having large for gestational age babies who become overweight infants and toddlers, and overweight school-age children, adolescents, and then the cycle continues. So pregnancy seems to be kind of the prime time when we could have this dual impact on the mother and the child. Which takes us square into healthy eating, active living, or HEAL, the intervention that we'll describe next. So HEAL is a collaboration between 3 entities at the University of Texas Health Science Center. It's a collaboration between UT Physicians, which is the clinical practice arm of the Health Science Center, the McGovern Medical School, and the School of Public Health. And this pilot initiative was funded back in 2004 through the 1115 Medicaid Transformation Waiver Program, also called DSRIP, which stands for Delivery System Reform Incentive Payment Program. And the goal of the program was primarily to address gaps in service, mainly preventive services. And a major focus of this program was maternal and child health. And so Texas, taking one step back, Texas, the reason this program was initiated in Texas was because Texas did not participate in the Affordable Care Act, and so in Medicaid expansion. So this was a way to have those services be available to a population that is in need. So this is the logic model for HEAL, and if we look at the logic model, sort of going from left to right, we have the various program objectives. So targeting the mother's diet, physical activity, engaging in regular prenatal care, and infant feeding are some of the primary targets, which then lead to improved behavior in the mother during pregnancy, as well as improved family routines as they pertain to healthy eating, physical activity, cooking skills, sleep routines, screen time, and other sedentary behaviors as well, which then translate to improved health outcomes in the mother and also in the child, as well as improved systems level outcomes in the clinic and the home environment as well. So HEAL it was implemented starting, HEAL was implemented starting 2014 in the UT Physicians clinics. And it is embedded within the electronic medical record system. So it has its own virtual clinic to facilitate referral and recruitment and tracking of the patients who are enrolled in the program. The eligibility criteria for patients to be enrolled in HEAL is less than 28 weeks pregnant, BMI of over 25 at first prenatal visit, and Medicaid or Medicaid eligible. I just want to remind everyone that this was not a research study. This was a service delivery project. We really wanted to see if we can implement HEAL within a system where it can be part of standard of care for patients receiving their prenatal care. and specifically targeting at-risk patients who are Medicaid or Medicaid-eligible. So HEAL actually has two targets, as I mentioned, the mother and the child, and the Table 1 outlines the specific targets that we're interested in with regards to the mother: engaging in regular and early prenatal and interconceptual care, achieving a healthy weight gain during pregnancy, returning to a healthy weight post-delivery, and preparing to breastfeed. There are several targets with regards to the infant as well, and there is a HEAL infancy program, so mothers who graduate from the HEAL pregnancy program can go into the HEAL infancy program that is concurrently being implemented in the pediatric clinic. But for the purpose of this webinar, we'll primarily be focusing on the pregnancy part of HEAL. So the HEAL formula is simple. Women who are, so we have a dietitian that is on site at the UT physician clinics who participates in actively enrolling the women into the HEAL program. So works with the clinic providers and other clinic staff in identifying women who are eligible, approaching them, recruiting them, and there's a first one-on-one intake session that happens, and then the women get recruited into the 5-week HEAL program, which are primarily in a group education format. The formula that is implemented across each of the sessions focuses on health literacy, improving cooking skills and exercise, and then also collaborating with the local food bank and Brighter Bites, which is a local nonprofit for produce distribution and some nutrition education. So I'll hand it next to Melissa Dano, who's the program manager for HEAL, who will dig a little bit deeper into each of the components.
Fantastic. Hi, everybody. So we're going to start by talking a little bit about the different HEAL program components, right? As Dr. Sharma was saying, we kind of start with that one-on-one session with the registered dietitian, and that's really an opportunity for our participants to address any personal issues. We've got a lot of things going on in pregnancy, a lot of, nutritional impacts. A lot of women have questions about acid reflux. Maybe they're having problems with constipation. Anemia is pretty common among our women. So this is a chance for them to kind of sit down one-on-one with the dietitian and address those individual concerns. After that, they go to our group session. So they are held once a week for 5 weeks, and that's with a community health worker. What's important about that is it occurs weekly, right? So they're getting that kind of back-to-back, and it also occurs in a non-didactic fashion. So that's a really important element of HEAL. And we also use these motivational interviewing techniques. The open-ended questions really start to encourage dialogue, and that's how we start to build that relationship with the participant. We're affirming positive behaviors, which is super important. I remember Dr. Nader, kind of the father of our program, talked a lot about celebrating those small wins, and that's really important for our participants. If someone's gone from having 3 sodas a day to 1 soda a day, that's an accomplishment, right? We're celebrating that during group. Again, using the reflective listening technique, that's important because that starts to develop that respect. People want to be heard. A lot of times in a provider setting, they may not feel that they're being heard. So that's another really important element of having these community health worker-led sessions. And finally, as another element to the motivational interviewing techniques, there's the summarizing, which kind of underscores everything that's going on above. So our groups generally last for about 90 minutes. There's 4 major health topics that we cover. We discuss making the most of your prenatal appointments or provider engagement. Again, this is an important aspect of what we do in HEAL. Again, having that clarification, encouraging participants to really advocate for themselves, to open up that dialogue between themselves and the provider. And again, having the community health worker sort of as that bridge, right? How I walked out of my appointment, I don't understand what they told me. I'm frustrated. I leave, I go home, I complain to my family, and that's it. No, we're at HEAL. We're talking about what happened. We're talking about speaking to a nurse, speaking to other staff members, really getting engaged in what's going on and getting the most out of your prenatal appointments. Preparing for breastfeeding is another great topic. We have a lactation consultant come in and speak with the participants. This generates a lot of questions, a lot of feedback. A lot of women are concerned about breastfeeding. They're scared to breastfeed. They're worried it's going to hurt. They're worried about the effect it may have on their bodies, and this is an opportunity to discuss that. Also, they may be able to speak with other women who have breastfed before, and now you have that peer-to-peer interaction that's really helping to bolster that support and prepare the mother to attempt to breastfeed. Physical activity is another great part of the sessions. We'll do things like yoga, stretching, and the women definitely enjoy that. It's also important to understand the food environment. We talk about label reading, shopping on a budget. All of that really just helps to cover different bases of the Healthy Eating Active Living program and how can we move toward these positive behavior changes. So we also address cooking skills. So during this part, we have a distribution of recipes. We talk about several different topics. Sometimes we'll have produce that may be unfamiliar to people. So if we have something like pomegranates, this is one way to open a pomegranate. Have you ever eaten pomegranates, etc. It could be something as simple as a sweet potato. Can we make a sweet potato hash? What else can we do with a sweet potato that we haven't tried before? So these are all just more opportunities for discussion, for interaction, and for sharing. Again, this is another opportunity for that peer-to-peer discussion. One of the great things about being in Houston is we have a very diverse population, and someone may have never seen jicama. Someone else may have said, you know what, we just squeeze some lime and cayenne on there and you're good to go. Oh, that's fantastic, right? And they're getting that from another peer. So it's not just a dietitian who's expected to have this perfect diet saying this is something to eat. It's peers saying, hey, these are some of the things that we can eat together and share. Physical activity, this is one of our favorite parts. It's one of the most unexpected parts. We get so much feedback about this. Women go in, a lot of women go in not expecting to like it, and they come out loving it. Our community health workers have done a great job, again, in building that relationship with the participant, getting them to try these new things. It's so important. And then they come back and they say, you know what, my back feels better. You know what, I'm sleeping better than I have before. So this is a really important and exciting component of the program. Finally, we have the produce distribution. We talked about partnering with the Houston Food Bank and with Brighter Bites to help provide patients with 2 bags of fresh fruits and vegetables to take home. So we're not just saying, hey, look at this pomegranate, you know, now here's a pomegranate in your bag. Now you can try it. You can try it in a salad. You can come back the next week. You can talk about what did you do with it? How did you maybe vary the recipe or a new way that you found to use the produce? And it's risk-free. Sometimes people are afraid to buy something. Hey, I don't want to waste money on something my family isn't going to eat and something I don't know how to prepare. But now you're having that opportunity and you're having that experiential learning that will help to motivate you and encourage you and your family to partake in these healthy foods. Goal setting. I love talking about goal setting. It's actually, again, it's an exciting part of the program. Participants are giving these healthy goal tracking sheets each week so that they can track their fruit and vegetable consumption, they can track their water consumption, they can track how much they are walking or their physical activity. And then at the end of the sessions, at the end of the 5 weeks, we do give incentives to people who have consistently tracked their goals. It's another fun part of the program. It's another motivating factor. It's another way for women to share how they're meeting their goals. They're writing down their goals. They're going through a process. And we're coming out in the end with these wins. Evaluation.
All right, thank you, Melissa. That was a great description of the program. So clearly, this is a clinic community partnership because the classes are held, the group sessions, even though the recruitment and tracking is done in the clinic with the clinic staff, the community health workers implement the program in a community setting, and whether it's we've had it at a church, we've had it at the School of Public Health in the teaching kitchen, and we've also implemented the program in the clinic itself. So, so the program's implemented in community settings or in the clinic location as well. So we want to know, since this wasn't a research study, there wasn't an opportunity to randomize anybody or have a control group. However, we did want to have an evaluation component where at least we would track whether we are changing the outcomes that we wanted to change. So we have a paper published recently in Preventive Medicine Reports, but I'll take some time to sort of present some of the highlights of our preliminary evaluation. So we conducted this evaluation. It's ongoing, but we primarily are presenting the data from March 15 through October 2015 through October 2016. And so this was a one group pre-post evaluation design. And we looked at we had about 329 women who enrolled in HEAL, and of those, about 210 women completed the program, and we had a pre and post assessment on them. So that's about a 64% retention rate. We had, when we looked at the data, there were a few more women who actually completed the program but did not complete a post assessment. So we don't have any data on those women, even though they finished HEAL. To look at the pre-post changes, we used an ANCOVA. We controlled for several of participants' demographics, which including age, ethnicity, income level, which we'll look at in a minute. And then we also wanted to see if, since we didn't have a control group, we at least wanted to see if attendance a session impacted the outcome. So if the women who attended more sessions, did they have better outcomes? And so we had an interaction term in our ANCOVA model as well. So here are some demographics. So a majority of our women were about 28 years old and about 21 weeks pregnant. Their self-reported pre-pregnancy weight was about 195 pounds, and their BMI pre-pregnancy was 32. So that's the mean BMI, and so that puts them in the obese category. The baseline BMI of all our participants, which is the BMI that we measured, was about 35. And then just in the dyad, the 210 participants that completed the pre-post assessment, the baseline BMI was about 34. We also wanted to, so Houston is a very urban city. The clinics that we, specifically the UT Physicians clinics, are located in, the ones that we targeted were in highly urban areas. And we wanted to kind of see how far the women were traveling to come to the clinic and come to the group sessions, which were held, as I mentioned earlier, in locations close to the clinic or sometimes even within the clinic. So the women were traveling quite a few distances, even as far as 10 miles or even further, to come to the clinic and group sessions. So when we mapped it, the women's addresses, we were pulling in women from around the city. So breastfeeding was one of our main intervention targets, and we asked them about several questions on with regards to intention to breastfeed and self-efficacy and other sort of psychosocial factors related to breastfeeding. And we found that these are pre to post changes. So you have the frequency distribution pre-heal and then post-heal in red with regards to intention to breastfeed. And you can see that there was a significant decrease in formula only and breastfeeding and formula, the proportion of women who said that they would do either of those. But there was a significant increase in the proportion of women who said that they would do breastfeeding only from pre to post program. We also asked them about intention to exclusively breastfeed and to up to what age. And again, you can see that there was a significant increase in the proportion of women who responded that they would exclusively breastfeed for 7 months or more, while there was a concurrent decrease in the proportion of women who said they would exclusively breastfeed for 3 or 4 months or fewer than that. Similarly, we found an increase in the perceived benefits of breastfeeding with regards to the baby. We found that there was an increase in the proportion of women who strongly agreed that if a baby is breastfed, he or she would be healthier. And we also found that higher attendance in heal sessions was associated with higher perceived benefits. In looking at dietary intake, we asked them several questions from the FLASHE survey, which was developed by NIH. And it asked them about frequency of consumption of fruits and vegetables, as well as other foods consumed. While we don't have the opportunity to present all the results there in the publication, we did find a significant increase in the proportion, in the number of servings of fruit consumed. So you can see that post-heal, there was an increase in the number of women reportedly eating 1 to 3 or 4 or more servings of fruit as compared to before heal. And then we also similarly found an increase in the number of servings of vegetables consumed as well. So there was a decrease in those reporting 0 to 1, but increase in 1 to 3 or 4 or more servings of vegetables per day. Also, higher attendance in heal sessions was associated with higher intake of vegetables. Concurrently, we found a decrease in the intake of heat and served foods. So we asked them about frequency of consumption of heat and served foods in the last 7 days. And you can see that the proportion who said 0 times went up from 56 to 68%. And also higher attendance in heal sessions was associated with decreased intake of heat and served foods. As Melissa mentioned, we really have heal is very strong with regards to improving cooking skills and cooking techniques. And while we saw several changes, some of the more important ones was We saw an increase in self-efficacy scores with using basic cooking techniques. So 70 post-heal, we had 73% of the women who said they were extremely sure that they could use basic cooking techniques with basic ingredients. And higher attendance in heal sessions was associated with higher self-efficacy. Moving on to physical activity, the women who participated in HEAL did a lot of physical activity when they came to the session, but also were encouraged to have a physical activity goal for each day. And here also we saw that the proportion of women who were physically active for at least 30 minutes in the past 7 days went up from pre to post heal. So while pre-heal, we had 17% of the women who had 0 days of physical activity for 30 minutes. That decreased to 4%. And then concurrently, as you can see, the other proportions went up. We saw this similar change when we asked them about walking for at least 10 minutes at a time during the past 7 days. And also for both of these physical activity variables, higher attendance in HEAL sessions was associated with higher time spent being physically active. So while we used quantitative surveys to get the pre-post evaluation feedback, we also collected a lot of process evaluation data from participants to get information on feasibility and acceptability of program components. And Melissa will talk about that next.
Right. So we do ask several questions of the participants as we're kind of wrapping up, one of which is, what kept you coming to class? So this is some feedback that we've gotten from the women from our surveys. They really enjoy that social support, meeting other women and interacting with them. The yoga is always a big hit. People are sad if they miss it because it gets really good reviews. They also get a handout too. These are more examples of some yoga poses that you can practice at home. Also, the warm, supportive environment is something that we get a lot of feedback on. The information, and again, the social interaction, and that really that support and care is what our participants really find important. Right? It's a dynamic time in your life. It's a time of change. It's a time that could be very, fraught with worry and other things, and kind of provide a place for people to reflect and think about what positive changes can we make going forward. What were some of the highlights from the class? So some of the feedback: I learned how to stay away from the wrong food, read labels. That's beautiful. We love to see people label reading, and how to use different vegetables, such as beets. Beets actually got a shout out, people. That is huge. I give a lot of credit to our dietitian who has like at least a dozen beet recipes under her belt. And it's just beautiful to hear people make that change from really not eating too many vegetables, from being really wary, to actually saying something like, I like beets now. The lactation consultant, as I had mentioned before, is also very popular. People enjoy that education that they receive about breastfeeding. Another comment about the exercise tips. I was previously afraid to work out because I was pregnant and did not want to hurt the baby. And that's something that's also common that we hear. Some women or their families feel like they have to put them in a glass case and leave them there for 9 months. But women are happy to see what they can do and kind of get a lot out of it and end up feeling a lot better. List one healthy habit that you've improved during class. That's another question that we ask. Again, incorporating more fruits and vegetables into their diet, drinking more water. We've got all these great stories about water, about, someone who's having headaches and the doctor was like, well, you could take Tylenol. Well, you could, I don't know. And she spoke with our community health worker who's like, hey, are you drinking more water? Was that one of your goals? Boom, headache's gone. Cooking with less salt, that's another big win. We know there's a lot of hypertension in the communities that we work with. And again, incorporating these healthy habits, they're walking more, they're cooking with fruits and vegetables, you know, wheat and less salt. Shout out to wheat. We get the people to try, you know, these other products that they may have not tried before and actually enjoy them. We've also gotten some great provider feedback, so that's also lovely to hear. We did hear from a provider who was concerned about his patient's weight gain trajectory. She had gained a lot in her, I think she was in her first or second trimester, and it was a concern. And when she went back to her appointment, you know, he saw her and he said, wow, this totally came to an end. You had been gaining every week. What's different? And she told him that she started going to the HEAL groups. And we were really pleased to hear that feedback from the provider. We've heard other providers talk about how it's one of the best programs that they've seen come through their clinics. And to have that support is really important. And it's just nice to have that feedback from both sides. So what's next, Dr. Sharma?
Thank you, Melissa. So as we've talked about for the last 30-odd minutes, the HEAL program really has been implemented as a way to optimize the standard of care for pregnant women who are primarily from low-income populations. And so one of the things that has been encouraging over the last 4 years is that it really has been the seamless implementation. Of course, initially it took about 6 months to integrate the program into the clinic systems, and especially because it was a departure from regular practice, getting the providers and the clinic staff trained, our community health workers and dietitians trained, partnering with community providers like the food bank and Brighter Bites. All of those pieces took about 6 to 9 months to be put into place. But since then, it has been a seamless implementation to really optimize what the experience has been for the patients. So what's next? We really wanted to learn from this experience, and I think we've learned a lot. And we now feel that we are prepared to take it to the next level. The program was implemented through the DISRIP mechanism, and now that was DISRIP 1.0. Now this DISRIP 2.0 begins this October, with the potential for scaling the program to 10 clinics in the UT physician systems. Right now we are in 2, maybe 3 clinics within the UT physician system, and the plan is to offer the program to 10 clinics. And the question is, what would that look like? And like in all likelihood, potentially that could involve developing a train-the-trainer platform, and engaging the clinic staff in really implementing the program components where they are. And from a research perspective, our next step is to conduct a more rigorous evaluation. We are doing post-delivery follow-up right now of the women who have gone through the HEAL program, and we want to look at the various birth as well as post-delivery outcomes. But we also want to do a more rigorous evaluation of the program using a randomized control trial design. And then last but not least, we want to, our goal is to further strengthen collaborations. The program is a partnership between the clinic system, the School of Public Health, the food bank, and other community service providers. And we have learned, one of the things we have learned is that if you really leverage on all of these entities' expertise, you can really offer this optimal standard of care to the patient without a lot of added cost. Because, for example, the produce that we get from the food bank is primarily donated produce. and we collaborate with Brighter Bites to provide the educational materials and the recipes. So leveraging on the community service providers, it has really sort of been the key to delivering an optimal program. So strengthening those collaborations further is also what we're interested in. Last but not the least, we want to acknowledge our various partners and our community health workers and our dietitians, without whom we would not be able to implement HEAL, and also want to thank Dr. Phil Nader, the late Dr. Phil Nader, without whose vision HEAL probably would not have happened, and we're very grateful for that opportunity. So thank you. At this time, our webinar comes to an end. Our contact information is available here if anybody is interested. We're happy to communicate further or answer any questions at this time.
Thank you, Shrila. Yes, so if you have any questions, please put them into your chat box. So I'll start off with, did you guys see mostly first-time mothers signing up for the program, or was it more of a mix?
It was definitely more of a mix. You know, if we were to do a research study, we would probably target first-time mothers. You know, but this was, since this was a service delivery project, this was a mixed group of women. And that's an interesting question, if I may add, because we had many mothers who, you know, had other children and now were pregnant, and they had never breastfed before, and we found that after going through HEAL, that was the first time they had breastfed their babies. They had never prepared their own baby food, but after HEAL, this was the first time they were preparing their baby food. So it was interesting that we were able to kind of see that change in mothers who may not be delivering for the first time. So I thought that was interesting for us to see.
There's also a question on if there's any aspects of the program that teaches the participants healthy habits for the entire family, and also once the baby is ready to move on from breastfeeding.
Yeah, well, we do encourage our participants to bring a family member, so they could bring a spouse or, you know, a parent or, you know, a sister, cousin, etc. And we find that that's really helpful, because once they not only have the peer support from the women in the group, but when they're able to bring a friend or family member, now they're able to bring that support home, and they're able to support each other. So that's something that we really like to see. Sometimes the guest gets very involved, and they're, well, hey, can I get a copy of the recipe? Can I get a copy of that information? So it's really nice to see that that extra level of engagement. And as far as support for other feeding of the infant after breastfeeding, during the infancy group, we do talk about timely introduction of other foods. How long are we exclusively breastfeeding for? When are we going to introduce new foods? How do those foods get introduced? So we do get a chance to discuss that, and that generates lots of lively discussion. But it's a really good, you know, kind of informative process where we talk about things like, you know, not putting cereal in the baby bottle, about trying one food at a time, about, you know, blending, you know, a fruit or boiling something and then putting it in the blender, adding some water, depending on the age of the baby. What are the cues, right? What are the physiological cues that the baby is ready to start eating table foods, or to start eating something besides breast milk, and also encouraging that continued discussion with the pediatrician.
Yeah, I think one of the major targets, what we're trying to really do is create this social support system for the women as they're going through pregnancy and also infancy, simply because that is a time when they need it the most, and it's a time to really create that foundation for healthy behaviors in both the mother and the child. So social support by bringing a friend, family member, engaging their support system into the program is highly encouraged.
So we have a question here that asks, were most of the women working? If yes, did the specific time of day affect the participation in the services provided?
Yes, a lot of the women, especially our pregnant women, a lot of them are working. We generally offer our groups in the evenings. We've offered them in the morning as well. Our infancy groups tend to be offered more in the daytime. But there's demand for both, for sure.
Yeah, and a lot of I would say about, if I remember correctly, it's about 30% who are full-time employed. I'll have to check on those numbers, but yes, which is why initially, as we were setting up those initial 6 to 9 months, we actually collected a lot of this qualitative information from the UT physician patients in regards to what would be good times to offer the class. So the pregnancy classes in the evenings after work, they get, and it's nice because they actually come, they get to focus on themselves and even they get almost a full meal as part of the program. When they come, and so it's the time of the day when they can actually focus on themselves and their baby. So we just looked up the numbers, and it's 43%, so pretty big chunk are employed full time.
So we have a question that asks, what type of professional/educational background did the community health workers in this program have?
So we actually have partnered with community health worker training programs here in the city. So these are they're Texas certified community health workers, and so we actually start by getting their interns as well. So we get every so often we get community health worker interns. They come from varied backgrounds. The ones that we have employed, that's 3 that you see on our presentation, Shamel, Esco, and Chelsea, have had some background in regards to either health or nutrition or working with pregnant women and low-income populations. So when we were hiring them, we kind of screened them for some prior experience in these areas. Melissa, do you have it?
Yeah, a little bit of a kind of nursing background, and health education background.
Yeah, and then they go through. We train them in the HEAL components as well. So it's the idea is to have these community health workers sort of be those agents of change for those various behaviors. So they do undergo a rigorous training so they can be comfortable in implementing the various HEAL components.
All right. We have a question that says, are mothers with gestational diabetes included? If so, have you compared their breastfeeding rate with non-GDM mothers?
So we do have actually several mothers with at risk for gestational diabetes or have been diagnosed with gestational diabetes, and we've actually pulled these outcomes out, and we're going to look at them. But what was the second part of the question, Veronica?
It was, if so, have you compared their breastfeeding rate with non-GDM mothers?
No, we haven't, but as I mentioned earlier, one of the questions on our post-delivery survey is about breastfeeding, initiation, exclusivity, and duration. And so we could certainly look at that, but that's a good question.
We also have some questions asking if these classes were offered in Spanish, or if there are any plans into implementing this program in Spanish.
So our community health worker is bilingual in English and Spanish. The classes are offered primarily in English, but the community health worker being bilingual essentially is able to, these are facilitated discussions. There's very little, so even the lactation consultant is bilingual. That part is more didactic, but she's bilingual and she does her session in English and Spanish. But the rest of the sessions are primarily a facilitated discussion format where we use these various topics of engaging with the provider or breastfeeding to sort of guide the conversation, provide recommendations and directions for next steps. But the women actively participate, and the community health worker, being bilingual, sort of navigates it accordingly. Melissa, do you want to say something?
Yeah, and we do have printed materials in Spanish as well that we give, that we give to the participants who are more comfortable in Spanish. Often they may bring somebody with them who's bilingual. We've had some people who don't speak whose English isn't that great, but they speak other languages, and they've used that, opportunity to bring a friend or family member to bring that person in to kind of clarify whatever might be a little bit unclear. So that's definitely been a way to also reach other communities. And again, having the written materials, I think is helpful. Also, we're doing a lot of demonstration, right? Especially with the cooking demos. So there's parts of the class that you could just really kind of look and see and kind of understand and get the gist of what's going on. You could taste we taste in all languages, right? So there's that experiential learning component that also kind of helps to bridge that barrier, any language barriers.
But we have a facilitator's guide that we have developed that's in English right now, but there are plans to translate that into Spanish so that the entire program could be offered eventually in Spanish. But having a bilingual community health worker really is important to help facilitate some of those conversations as well.
All right, well, we'll stop there for time, but if you do have any questions, just make sure to email us at delhealthyliving@uth.tmc.edu. And again, this will be archived on msdcenter.org. You will find the webinar recording along with the presentation slides. So I want to thank Shrila and Melissa. Thank you so much. And thank you, everybody, for listening.
Thank you. Great. Thank you.